invite you all to take a seat. We're going to start broadcasting in just a couple of minutes. Could you please turn off your cell phones unless you're on call and need to have them on vibrate mode? That's fine. Actually, cell phones on a silent mode can get in the way of broadcasting, but it's all okay. So I'm just waiting for my high sign from my team. I want to welcome you here tonight. I'm Carol Jenkins, Executive Director at Cystic Fibrosis Research Incorporated. And before beginning, I'd like to note that no information presented tonight is intended for a patient's diagnosis or treatment. As always, we urge you to work together with your healthcare team. Tonight, we're really looking forward to our presentation on the new age of small molecular therapies. And I'd like to give a special thanks to Genentech and Aptalis for supporting tonight's event. Their support pays for this venue, the refreshments, the studio we have constructed here, and other costs associated with the program. Tonight's program is being produced by your CFRI Live team. That's Eric Martin, Scott Wakefield, David Suhu, and Joanne Davis, who is tracking questions from our online participants. We are live here at the Crown Court Plaza Cabana Hotel, and I urge you all to ask questions, whether you're here in the audience or part of our online community. Hello especially to those of you who are in the hospital or working through treatments at home. We're really glad that you can join us. And finally, thanks to our volunteers tonight for serving food and helping us with our cross-infection guidelines. And now just a few words of introduction for Dr. Dennis Nielson. Dr. Nielson is director of the UCSF Pediatric Cystic Fibrosis Center and Division Chief of Pediatric Pulmonary Medicine. In his research, he works to better understand cystic fibrosis and explore new therapies. His list of background credentials and studies is a long one, and I'm here just going to note that an active clinician, Dr. Nielson's name has appeared for many years on the Best Doctors in America list, as well as on the U.S. News and World Report Best Doctors list. He brings us a wealth of inspiration and cutting-edge knowledge tonight. Please help me welcome Dr. Dennis Nielson.
Well, thank you, Carol. That was a very nice introduction. I'll do my best to live up to it. There we go. All right, we're ready to get started. And I do like to do these things informally, so please feel free to ask questions. And I see we have a microphone here so people can come up to the microphone and ask. So what I'm going to talk about tonight is a sort of reverse trip. You know, in medicine and in medical science a lot, we try to generalize, try to understand the big truths that we need to resolve. But tonight I'm going to sort of go in the opposite direction. We already know a lot about about our one new major breakthrough therapy for cystic fibrosis. But I'd like to take it back from sort of the big picture to the individual patient and talk about what I think this means for individual patients and where this might lead us in the future. So a lot of people in this room, maybe all of you, know this list extremely well, know it better than I do because you live with it. You know, I prescribe it, I don't live with it. And I know at least some of the people here live with this every day, that, you know, they have their enzymes, They're giving nutritional supplements. Some patients have gastrostomy tubes. You're pounding on chests, or you're using vests or various devices and taking a lot of different medications to try to keep your children healthy. What I think is going to happen in the next few years, that the list is going to have this new line added to it, which is we're going to do pharmacologic correction and potentiation of the CF protein. So what do those two terms mean, correction and potentiation? Well, we'll talk about it a little bit. And just as a brief review, again, I apologize if people feel this is too basic. You all know this pretty much, that if you look in the lung, in the lining tissue of the lung, the submucosal glands, if you look in the epithelium and the pancreas, what you see are cells that move salt and water. And one of the important channels for moving salt and water is the CF channel. We know that it's a very ancient channel. If you go back to the discovery of the location of the CF gene, there were a series of papers that were published simultaneously in Science that showed, one of the papers showed that this gene was present in various forms in virtually all creatures, humans, and if we think of humans at the top, which we might argue about, but if we're at the top, and viruses and other small microbes are at the bottom in terms of the evolution of creatures, then you have to get down to crickets before this gene goes away, before you don't see it anymore. So the Xenopus laevis, the African toad frog that we use in the laboratory, has a CF gene. We know that dogs and cats and pigs and sheep and mice have a CF gene. So you really have to go pretty far down before it goes away. So that suggests that it's an important thing because it's persisted in all the various species that have developed over eons of existence. So if that protein isn't there, or if it doesn't function properly, then what we see is here, this shows a protein that's defective, but it's present. We know that the majority of CF patients just don't have the protein there. And as a result, then, the chloride ions can't move through the top of this cell. That affects how much fluid is there. And there are these little projections that you see on these cells. These are, in the respiratory tract, these are called cilia. And they sit there and they wave in a very organized fashion that moves the mucus up the airway and helps keep the lung clean, because the mucus is there to trap organisms, microbes, dust particles. It's a very important part of the defense mechanisms of the lung. And if you don't have enough water there for any reason, the mucus tends to sort of get trapped on the top of the cells, and it just sort of builds up over time, and you have a problem, and you have something that you can call, or that we do call, cystic fibrosis. We know enough about CF that we have various classes of CF mutations, so that we know that the class 1, for example, is a very severe mutation. Class 1 through 3 tend to be the most severe, although there's variation even within those classes. So class 1, the gene just doesn't get translated and you don't get any production of protein. Class 2, which is delta F508, you get production, but then it gets broken down and degraded in the machinery that goes from the nucleus of the cell to the surface membrane. There's something bad that happens, and it's seen by the cell as being defective protein, and it gets degraded and never makes it to the cell membrane. So it's as good as if it never happened, that it was never produced. So again, very severe type of mutation. The class 3 mutation, which we're going to spend some time talking about today, because this is where Kalydeco works. You develop the protein, you move it through all the apparatus, the Golgi, the ER, all of those different places in the cell, and you insert it into the cell membrane. But the problem is that channels, ion channels in cells have gates. They have a gating mechanism. And this thing is there. If you can open it up, it actually conducts pretty normally for the most part, but the gate is stuck, closed. And so it might as well not be there for the most part because it just doesn't open. And as a result, again, the class 3 or gating mutations tend to be quite severe. And they account for all of them together. About 5% of CF mutations is in this class. And then you have class 4 and 5, and some people say we should have a class 6. But class 4 is the conduction is abnormal, so the channel in this is too small, or the charges are arranged inappropriately so that the chloride ions, the bicarbonate ions, don't pass through normally. And then class 5 is you have reduced synthesis, or it gets turned over too fast, and so there's a deficient amount in the cell membrane. But it's there, and it may work reasonably well. And we know that all of these gene mutations that, we try to put them in these boxes, class 1 through 5. But we know that some of these mutations, if you fix one problem, say the class 3 problem, it still has a class 4 problem. It may have abnormal conduction, or it may gate improperly. So that mutations tend not to be completely pure in that regard. But you can class them this way in general terms. Okay, so let's come back to the question of what's a potentiator and what's a corrector. Well, these are sort of fancy terms, but we go to school a long time, so we've got to come up with fancy names. A potentiator is something that turns on the channel. It activates it. It amplifies its activity. The corrector is a drug that actually gets it there. So the correctors are the things that we're still having trouble finding. It turns out potentiators, we've got this drug now that we call ivacaftor that seems to do its job quite well. And we'll show you some data around that. And it wasn't all that hard to find. And actually in the laboratory at UCSF in our drug development program, we had 5 or 6 potentiators that actually looked pretty good. They didn't end up making it to the market, but it wasn't that hard to find molecules that would actually do this. To find the molecules that correct the CF defect, that actually take that protein and get it through the cell and get it inserted into the cell membrane properly, those have been tough to find. I'm sure most of the people, or all the people in this room, know that there are trials going on now where there are some candidate drugs that are being tested. There are many that people are looking for. There are publications that come out all the time trying to find some molecule that will serve the function as the corrector. All right, so we're trying to find these pharmaceutical agents that actually get at the basic defect in CF rather than just treating the aftermath of having CF. And this is this was presented at the CF meeting this last fall, a few months ago. And this is from a paper by Wilchansky, although if you look at that paper, you won't see a plot like this. This is sort of a reworking of the data. So don't look for it, it's not there. Although we may call it the Wilchansky plot or something like that, it's not in the paper, but people have reworked the data. And you can see that if you look at sweat chloride and you look at chloride movement or the CFTR activity, how well that channel is working, there is this line, it's not straight, and you can see these things that we call standard deviation or standard error bars. You can see they're pretty wide, so there's a lot of data scatter around these points. But this is a rough approximation of if you have 100% activity of the CF channel, which is down here with the non-CF patients, then you see, your sweat chloride is going to be somewhere in the teens or maybe 20, which is the sweat chloride concentration of someone who doesn't have any CF mutations. And you can see carriers, their CF, or their sweat chloride tends to be a little bit higher on average, but not enough to discriminate between carriers and non-carriers. And then you get up into the mild CF, the pancreatic sufficient. That's what PS stands for. Here's the CFTR-related disorders would be like the CF mutations that end up causing just male infertility, and maybe a little sinusitis or nasal polyps or something, but really not a lot of really bad stuff and certainly not life-threatening disease. And then you see the classic severe CF. And what you see to get from classic severe CF down to this milder situation, you're looking at least 15 or 20 points change in the sweat test. If you go from a sweat chloride of 100 to a sweat chloride of 80, you should in general have a little milder disease. But again, there's a lot of data scatter, and we'll look at some of that in a few minutes. All right, so this is some of the data from the clinical trials of ivacaftor superimposed on this Wilczynski plot, where you're looking at sweat chloride versus CFTR activity as measured by a nasal potential measurement. And you can see the various doses. So 25 milligram twice a day dose of ivacaftor. The sweat chlorides, dropped a little bit. And that should represent some increase in CFTR activity. At doses 75, 150, 250, you see it move further down so that you are actually in a range where at the usual dose, which is now 150 twice a day, you're somewhere around 30% on average of normal CF activity. Well, what does that do for you? So this is one of the plots from the New England Journal article that came out in December of 2011. The 48-week, or basically a year trial of ivacaftor in about 150 patients, and there's a placebo arm, and there's the active med arm. And you can see that the sweat chloride, that there's this huge drop, that on average the patients had a sweat chloride of around 100. And on average, they dropped about 45 to 50 millimolars, so that they actually ended up on average being in that indeterminate range between 40 and 60. The thing that you don't see here, we'll see in a few minutes, is that this is a little deceptive because you see those little bars, the error bars? These are standard errors. Standard error tells you, so if you're within 1.96 standard errors on either side of a point, that tells you that you almost certainly, somewhere in the middle of that range, you have the real average. But it doesn't tell you about the variability. Because what you have to do then is take the square root, the standard error is the standard deviation divided by the square root of n. So the square root of, let's just pick a number, 75. The square root of 75 is 8.66. I know that because I calculated it earlier. I'm not that good. My math isn't that good. But, so it's about 9, okay? So in this study, you have to take those little bars and multiply them by about 9, and then you see the standard deviation bars, and all of a sudden they're going to get a lot bigger. And that's going to show you what the standard deviation says, that if you have 1.96 standard deviations on either side, then there's a 90% chance the real value, the true value, is somewhere in that range. So now you're starting to see what the data scatter is. So we'll come back to that in a minute. But a big change. And on average, and here you can see these bars are much wider, so there's a lot more data scatter. But on average, patients gained about 3.5 kilos, which is 3.5 times 2.2, so it's about 8 pounds that they gained on average. And there were some that gained more, some that gained less. And you can see the people taking placebo didn't really change. And if you look at who ended up having what they called an event, so they're looking at event-free subjects, most of the events were exacerbations, a lung infection, increased cough, sputum, and so on, a reason to give antibiotics. And there's about, the difference here is it's about a 1/3 drop actually a 50% increase in event-free subjects in those getting the drug. So again, you know, you're kind of looking at averages. And if you look at the absolute change in FEV1, you see that the placebo group had a slow decline, which is typical for CF. And you can see that the group getting the drug came up, pretty much held their own, little tail off at the end. Hard to say if that's real or not. But there was a real and sustained difference, although it's only 10% predicted points in the FEV1. So if you don't recall, FEV1 is the forced expiratory volume in 1 second. So if you take a big breath and push it out really fast, you get out about 90% of that breath in the first second. And it's a pretty reproducible number that we use a lot in the pulmonary business. So, you know, this is a significant finding. But again, look at this. Those are, again, standard error bars. So the standard deviations are quite big. You multiply each one of those by a factor of 8 or 9. And then you'll see the standard deviations. Okay. Is this a dream come true? We're going to talk about it. I do have to confess, though, that's my granddaughter. Not Cinderella, the other one. Okay. So let's come back to this data. We talked about how small these bars are. And if you go in on PubMed and you pull up the paper, there's a supplement. You go into the supplementary material. Actually, this is from two of the earlier studies. But this is from the 2010 article. You go into this supplement. And then what you see is this first one is a 14-day trial with ivacaftor, which was then called VX770. And then on the other was another study where they looked at 14 and 28 days. And they're looking at sweat chloride. So here's your placebo group in both of these. And then here are your various doses. So these were dosing studies. And you can see at 150 milligrams twice a day, which turned out to be the dose that we're using, you see the average number, the average decrease is about the same as in the larger study. It's about 50 millimolar drop. But look at the scatter here. Here you've got a patient whose sweat chloride went down to 20, which is completely normal. And here you have somebody whose sweat chloride is 65 or thereabouts. And if we go over into this data set, you can see we've got patients at 150. Here's one whose sweat chloride is close to 90 still on the drug. And the same thing over here at 28 days. And here's a patient, again, who's, you know, down in the 20s or maybe 30. And over here at 4 weeks, same. And we know that this drug changes the sweat chloride. You're pretty well done changing after a few days. You're about 90% of the way there after 3 days. Because they do show those data in these studies. But unless you go into the supplementary material, you don't realize how great the scatter is. And you know, I don't know exactly how to explain this. I don't think anybody does. I saw Dr. Wine walk in the room. Maybe he can explain it for me. But
I was just going to say you've done a beautiful job of calling attention to the standard error and the standard deviation. And I was waiting to ask you.
yes? What were you going to ask?
We should talk about it later because we actually do have some ideas on this. But one of them that I'm convinced that you as a clinician would know better than anyone, to my astonishment, and I'm not a clinician, but to my astonishment, as simple as it is to take 2 pills a day, they're not always taking 2 pills a day.
Yeah, so that's one of the possible explanations is they weren't taking the pills, although you would think people could do that for 2 weeks. I mean, it's 1 pill twice a day. Or maybe they skipped one and, you know, things would change rapidly. Or maybe they just don't respond as well. And we don't really, at this point, from the data, looking through the studies, going through the supplementary material, I couldn't see any way of addressing that question. But there's a lot of scatter. Not only that, but this is a little subgroup analysis or subdata analysis that Tony Dermowitz and friends who were also part of this study published in Chest here recently. And here what they plotted is, on the left-hand side, is the absolute change in percent predicted FEV1 from 2 different studies. And on the horizontal axis, you're looking at the absolute change from baseline sweat chloride. Now, these are only patients who received the drug. There's no placebo data here. And what you see is that there's, again, huge scatter, and there's no trend to tell you that there's a correlation between the change in sweat chloride and the change in lung function. So they argued that sweat chloride was not a good outcome measure or a good predictor of response because you don't see any slope in these data. However, this paper, which is now published electronically, just came out, includes Dave Rodman, Van Gore, people who work for Vertex. They went back and looked at their data. I think it's the same data set, but instead what they did was they looked at the placebo group and the group that got the drug. So the open upside down triangles are the placebo patients, and the right side up dark triangles are the patients who got the drug. And again, you see this huge scatter, and you see no trend within either cluster towards a correlation between improvement in sweat chloride and improvement in lung function. But you see that the people who took the drug did a whole lot better than the people who didn't. At the same time, you look at this data, and you look right here, look at the placebo group. Here's somebody whose FEV1 went up 40%, and he's getting placebo. And his sweat test didn't change. How can that be? He got some antibiotics, he started doing his treatments, he took up long distance running. I don't know what he did, but something, something really good happened here for this particular patient. At the same time, you've got somebody over here where their FEV1 went down by 30%, which is not a good thing. They should be in the hospital. Their sweat chloride didn't change much. And here's somebody over here where on placebo, their sweat chloride changed by 25 points. How does that happen? I get upset with my lab if there's more than about 5 points variation from measure to measure, and we've been measuring more repeat sweat chlorides lately, and I've been very impressed. They do a good job. And I'll show you some data from a kid where my standard deviation for 4 measurements is 1. I got 95, 95, 93, 95. And the 2 sets were 12 years apart. I'll show you this. Pretty reproducible. And then you look over here, similar to the Dermowitz paper, and you look at this scatter, and you've got people where the sweat chloride decrease is huge, and they don't get any improvement, or you've got this one person down here where there's a 25% drop in their FEV1, and they've got a more than 40 millimolar decrease in their sweat chloride, which I would think would be great. So why is there no correlation? Well, I don't know all of the answers to that question, but I think part of the problem is that FEV1 is not determined just by how well or how normal your secretions are. It's also determined by what the bacteria in your lungs are doing. Are you doing your other treatments? There are a whole host of confounders that you can't take into account in this kind of a study. Okay, so what happens in real people, in individuals? And one of the things I'm going to argue tonight is that some of the most important things that we can learn about correcting and potentiating CFTR comes from the extremes. So let me show you an example. This was published as a case report in the Journal of Cystic Fibrosis recently by people in the adult CF program in Dayton, Ohio. So they had a patient, 508, G551D, just like the patients that were in the ivacaftor studies. 39-year-old male, diagnosed with meconium as an infant, has CF-related diabetes for the last 2 years, bad thing to have. 5 strains of Pseudomonas, probably all resistant to every antibiotic known to mankind. presents to the hospital in respiratory failure, starts on a transplant workup. This guy's in the ICU, starts ivacaftor in the hospital. And this is what happened. So he comes in on day 1. He has a pH of 7.25. Your pH should never be below 7.35. 7.25 is a bad number. It means you're in trouble. His PCO2 is 128. Your CO2 should be 35 to 45. PCO2 of 60 is considered respiratory failure. He's got 128. He's on death's door. People at this level usually are either comatose or delirious. If it comes on gradually, you seem to do a little better with it, but this guy's in serious, serious trouble. He's on 92% oxygen, or excuse me, he's on 60% oxygen and his saturation is 92. So normal saturation, is 96 to 100. So that's where he is. So he gets the usual treatments, IV antibiotics, aggressive chest physiotherapy, and he does get better. So after 2 weeks, which is day 15 right here, his CO2s come down to 77 about. That's still respiratory failure. And if he didn't have CF and he came in, if you went into the hospital like that after a head trauma, you would be intubated in about half a second and you'd be on a ventilator. So because he has CF and he has a chronic illness, they didn't do that. So 77, still bad, but his pH now is 736, so it's, he's obviously more comfortable. But he's still on 55% oxygen. But he was comfortable enough to do spirometry. So, the simple blowing test we have people do in clinic all the time. And he had an FEV1 of 0.88, which is 24% of predicted. It's pretty bad. But, back on day 1, if he'd been able to do that, who knows what it, it could have been 5% of predicted or some awful thing. I mean, he was in serious trouble. So there he is, 24% after 2 weeks of aggressive standard management of a CF exacerbation. Okay, so they start the ivacaftor on day 15, and he gets better, and he goes home. And then you look out here at this last one. So this is 6 months later, 188 days. You can see his CO2 is now 42. That's within the normal range. He's in room air. His oxygen levels are still a bit low. You can see 21% is his O2, so that's room air. His SAT in room air is 89%, which is low, but there are a lot of old-time emphysema patients walking around with SATs of 89, and you're quite comfortable on that. You might have a trouble up at Lake Tahoe, but you're okay with that. And you can see now his FEV1 is now 1.38, 36% of predicted, which is still not a very good number. But the guy's in room air, his CO2 is normal, and he's walking around. I mean, this is huge. This is a miracle. This just saved his life. And it took him off the transplant list.
Why did he start on day 15?
I don't know. They didn't say. There were a lot of things in that case report that they kind of left. They didn't measure the sweat chloride, so I have no idea how big of a change he had. It was, when I looked at the case report, it was kind of like, why didn't they tell me? I needed more information. But yeah, they didn't say. Okay, so let's talk for a minute about other gating mutations, and I'll show you why in a minute. So if you take the other 9 other gating mutations, which account for a total of 1% of all CF mutations, so 551D, the reason it was studied was because it's 4.4% of all CF mutations. You take the other 9 known gating mutations, it takes you up to 5%, so they're pretty uncommon. But if you get those and you put them into FRT cells, which are they're actually rat cells, thyroid rat cells, and you grow them up and you put them in a little chamber where you can measure chloride conductance, then what you can show, and you also look at little patches of membrane, so you measure individual channels, but what you see is if you take 508 cells, transfected cells, the white is the baseline, the dark represents the change on exposure to 10 micromolar ivacaftor. You see a little bump with 508, but not very much, and that's in large part because there's nothing there to work on. 551D, you see you start out really low, and you get up here, and that puts you up around 50%. If you look over on this side, you see chloride transport as a percent of normal. So 100% is here. This is the baseline for the normal CF, or for normals. And so the G551D patients actually get up around 50, 60% of normal. But look at these other mutations. I mean, here's one, G551S. There's a little activity, but golly, you know, you expose it to this drug, it's over 150% of the baseline normal activity. And notice normal. Normal, you expose a cell with the normal CF channel in it, you expose it to this drug, it conducts more chloride too. So it just turns on the channel. You know, it doesn't care which channel's there. There's nothing about this drug that's specific to G551D. And I'll show you some more data that says if you've got some CF protein in the cell membrane, it very likely will turn it on. It will increase what we call the open probability, the amount of time, the percent of time that it stays open. Okay, so look right here, S549N. You expose it to this drug, and the chloride transport is about 100% of normal, very close to it. It increases gating about 99-fold, and the conduction of this channel, in data I'm not showing here, but if you go back to this paper, you'll see it. The conduction is normal. So you end up with a cell that conducts chloride completely normally by exposing it to this drug for this particular mutation. Well, it turns out S549N is a Hispanic mutation, I think, because if you look at the general population, it accounts for 0.06% of CF mutations. If you look at Hispanic patients, it's 0.66, so about 11-fold more popular among our Hispanic CF patients than it is among our European patients. Okay, so a little friend of ours, 12-year-old girl with CF, diagnosed in 2001 at 14 months of age. I got called to San Francisco General to do a consult. One of 2 times I've traveled across the city to do this. And I've known her ever since. But she'd been admitted several times for bronchiolitis. Saw her, walked into the room. She's 14 months old. She has clubbing of her fingers. Bronchiolitis doesn't do that to you. So I asked them to please transfer her to UCSF where we could do a sweat test properly and work her up. Okay, so great patient, great family. They do everything you ask them to, faithfully. She's still admitted 19 times in 12 years, 8 times in the last 2 years, hasn't spent Christmas at home for 5 years. Wanted to join dance class at school, but she couldn't because she just couldn't do it. You know, she walks a block, she has to stop and rest. Her most recent FEV1s had dropped down to 33 to 39% of predicted. Pretty lousy. Okay, so S549N, class 3 gating mutation, one of those 9 others. 1811 plus blah, 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 a class 1 mutation. It's not going to help you at all. There's just nothing there. We put her on ivacaftor. This is what happened. So at diagnosis, actually, there are 2 points, 95, 95 when we diagnosed her. We brought her back when we got approval for the drug, which is another whole story, but we got it for her. And so baseline day 0, we brought her into clinic. We did sweat tests on both forearms. I didn't want to have her come back 2 days, so we just did one on each forearm. I got a 93 and a 95. We put her on the drug. We brought her back 2 weeks later, 19. That could be my sweat test. We brought her back at 28 days, and we did one on each forearm, 20 and 21.
And she's taking 150 milligrams twice a day.
Yep. This is her weight. We had to take her off the high-fat diet. We stopped the You know, she was getting Scandi shakes, I think, was what we were giving her. You know, we're encouraging salad and fruit. Anyway, I saw her at the Great Strides Walk here a couple of weeks ago, and she's got these rosy cheeks, and she's tall, and she's almost chubby. So, what happened to her lung function? Well, this is what happened. We started out at 33% on day 0, and this was about a month after coming out of the hospital. At day 14, 52%, 49% at 28 days, 57% at day 42. She was back in school, in PE, enrolled in 2 dance classes, walking wherever she wanted to at the mall with her mother, wasn't resting anymore. Had stopped coughing, so that nasty sputum-producing cough that she had day and night was completely gone. And in fact, at 5 weeks, we were kind of sitting there, well, you know, she grows out steno and staph, and now we don't know what to do because she's doing so well and she can't cough up anything for culture. What are we going to do? Did they go away? Have we cured her? What's going on? So we did a bronchoscopy. I didn't include a picture here. We went in and looked in her lungs, and the cultures did grow moderate steno and staph. Okay, so the same stuff she had before, but not very much. But the secretions look completely normal. So if you've ever seen a picture of what it looks like in the lungs of a CF patient, I refer to it as the river of pus. You look down the airway, and there's this river coming up at you of this nasty, thick, pussy material. Gone. And we know that we had scoped her some years ago, and we knew she had the river of pus. It was completely gone. The mucosa looked nice and pink and healthy and wonderful, and the secretions, they just looked great. So what's happened since then? So now we're out 6 months. So we got this just on the 13th. There's the last number. So what I can tell you is in February 4th, if you look at that number right here, you see she took a tumble. She had a cold. And a month later, we brought her back, and she only went up to 50%. Oh, dear. We had a problem here. But she kept working. She kept doing what we asked her to. She kept dancing. Oh, by the way, she did spend Christmas at home this year, too, for the first time in a long time. We just saw her on the 13th, 63%. Best number she's had in probably 4 years. This was her chest x-ray just before we started. And there are a few things you can notice here. There are these fluffy, hazy, patchy infiltrates around. You can see some changes of bronchiectasis. You see these dilated airways. You see her port right here. That's her port. There's her chest x-ray 4 weeks later. And she still has some changes of bronchiectasis here. There's a dilated airway. But all that patchy, fluffy stuff is gone. And it actually doesn't show as well here as it does if you actually see the thing on your screen at the hospital. But, all the markings are sharp now. Everything looks clear. Still abnormal, but dramatically different than it was before. And here's a CT scan that we did not long before she started the drug. And you can see she's got these dilated airways, bronchiectasis. And she's got these little areas, these little clusters of white dots here that sometimes people call a tree in bud, sort of like, the apricot tree, not quite in bloom. But you can see that the walls in these airways are quite thick. We just repeated her CT scan, and this is what it looks like as of last week. You can see there are still these holes in her lung, but now the walls of these ectatic areas are thin, which suggests that the inflammation is gone, and that tree and bud stuff is gone. So we didn't cure her bronchiectasis. I think this is irreversible and will never go away. But this is a very different CT scan from what we had 6 months ago. Okay, so why do I think this is important? Well, you know, the approach that is being taken right now, there are studies looking at the other gating mutations, and you have to go to Denver, you have to be an adult with one of those other gating mutations to get into the study. I think what we really need is we just need anecdotal data like this to show we need 10 kids with these gating mutations to get this drug, to look at the change in sweat test, to document very carefully their clinical response. You know, I would argue we don't need to do randomized, controlled, placebo-controlled, blah, blah, blah trials for every mutation, CF mutation that there is, because we'll never finish. We just can't wait that long. And if this were penicillin and it didn't cost $294,000, we'd already be using it off-label like crazy, right?
Could you define off-label?
Off-label means outside the FDA approval. So it's only approved for G551D. So giving it to my little friend, 12-year-old friend with S549N is off-label because she doesn't have G551D. She does have a gating mutation, and the in vitro data suggested that this would respond at least as well and maybe even better than the 551D. And her clinical course would suggest that that was true. So, you know, why not give it to all the people that we know that have gating mutations? Then you go from helping 4% of CF patients up to 5%. You know, that's a 20% jump. Small, but it's still 20% better. But there may be other patients that don't have gating mutations, because that's only 5% of all CF patients. There may be others that would benefit, and who would those be? Well, Dr. Van Goor presented in Europe and then at the CF meeting in October these data, where these are a bunch of CF mutations that he did the same thing with. He did FRT cell transfection and measures chloride transport, exposes the cells to the drug, and then looks for response. So what you see is there are a whole bunch of mutations here where you don't really see much. And so this is a chloride transport as a percent of normal, which is, you know, 100%. And you see some over here where I'm not even sure these people have CF. I mean, this F1052V is probably a polymorphism because it's nearly 100% of normal at baseline. So that's not somebody who's going to benefit from this drug. But you see this cluster of patients in here of mutations where, like, you know, for example, this one, S945L, you know, that's 10% of normal activity. And you give, you know, you expose the cell to it, and now you're up around 80% of normal activity. That would be a patient who'd probably benefit from this drug. And there are even things like, there's this one mutation here, A455E. We have 3 girls in our center ladies who have this mutation. They're all pancreatic sufficient. And here you have about a 3-fold increase in activity. It gets you up into a range where, you know, you might see a significant clinical benefit. Why wouldn't I want to try it in them?
What's the length of this test?
Well, no, these are just cells. And so they're exposed for, you know, they're exposed for days in culture, and then they're taken to the laboratory and tested. Okay, so let me tell you about another story. So we have a 7-year-old girl in our program who has pancreatic sufficient CF, and her sweat chloride at baseline is 60, just barely in the, you know, at that upper limit of the indeterminate range, but she has really bad lung disease. And it may be that she acquired a nocardia infection a few years ago, which is a really bad bug. We had to treat for 9 months with Septra to get rid of it. But in any case, she has very advanced lung disease, and she's only 7 years old. And she is pancreatic sufficient. So pancreatic sufficiency is a manifestation that there's protein present. It tells you your pancreas is still functioning. And if that's true, there has to be something there. And a sweat chloride of 60 tells you that there's something there. Otherwise, your sweat chloride would be 100 or something like that. So we did start her on the drug. And 1 week after starting her ivacaftor, her sweat chloride was 37. And we checked it 3 times. So it's, I think it was 38 plus or minus 3. That's a standard deviation, not a standard error. Of course, With N of 3, they're not very different, but pretty tight numbers. We had her in the hospital treating her. She improved on IV antibiotics in the first week that we treated her with standard therapies. We added the drug. We didn't see any clinical improvement. And then what happened was her liver functions test started going up exponentially. And we ended up having to stop the drug because it was just going up and we didn't see a plateau. And we didn't see any benefit, which was disappointing. But we did learn that in this patient with pancreatic sufficiency, we had a 23-point decrease in her sweat chloride. And according to the now famous Wilchansky, I have a hard time saying that, plot, that should confer benefit. And if she hadn't had the liver function problems, it would have been interesting to keep her on the drug and see what would happen to her, the progression of her lung disease and her clinical symptoms over time. And it still might have been worthwhile. Yeah, Jeff?
Did you say the mutation?
Sorry.
I did not. And she, let's see, I didn't put it in here. She has one known uncommon mutation that's a severe mutation, and her second mutation was a novel mutation.
Oh,
So we don't know what class it is, but she's pancreatic sufficient.
thank you.
Okay. So, you know, I think that this as a single drug, without waiting for the combination, that there are probably people out there that could benefit from it. And who would they be? Well, pancreatic sufficiency, that's a manifestation of some residual CFTR function. Patients who have a low sweat chloride. Did you know that 15% of 508 homozygotes, people with 2 copies of 508, 15% of them have sweat chlorides below 85? We have one whose sweat chloride is 58. We have another whose sweat chloride is 68. He was trying out for the Spanish national soccer team here last summer. He's a pretty good athlete. We have patients who have 2 severe genes, 2 severe mutations, but who are incredibly healthy. What does that mean? You know, I've got a girl who made the varsity cross-country team as a freshman who has 2 very severe, one type 1 and one type 2 mutation. What's up with her? Why is she so good? You know, if it's the exercise, then we better get all these kids out and get them on the track team.
Why would that make her a good candidate for the drug, though?
Well, because it suggests that there's something good. I don't know that she's a good candidate, but let me tell you why I think we should look at these. So we have obtained some private funding for a short-term trial of ivacaftor to explore this question. So the question is, can you choose candidates? And this won't, because I really hope that there are kids out there who have severe genotypes, severe phenotypes, just like the G551D 508 patients who would respond to this drug. I hope there are people out there who would do that, but I don't know how to identify them. But I do know how to identify people who have pancreatic sufficiency, whose health is far better than I would expect based on their genotype, whose sweat chlorides are low, because we have sweat chloride data on everybody, and we have genotyping on everybody in our center, and most centers do have most of their patients' genotype. To select out those patients who fit that description and do a short-term trial and see what happens. And because some of them are really healthy, I can't look at change in FEV1, and in 2 weeks I'm not going to be able to look at exacerbation rate, but I can look at sweat chloride, which, imperfect as it is, and I showed you the data that cast doubts on its sensitivity as an indicator, it is something that, and it's something that we do routinely, that everybody does in every center, that you can measure, that you can look for a change. So we're going to use that as our primary outcome. We're going to do what's called a double-blind, placebo-controlled, randomized crossover study. So 4 visits, baseline. We do a bunch of labs, put them on something, bring them back 2 weeks later, repeat a bunch of labs, do 2 weeks of washout, do another baseline, 2 weeks of treatment with placebo or drug, bring them back and do those measurements again and see what happens. And we're going to collect some other things, some blood. We're going to collect nasal cells with a little brush to culture in the laboratory to take and do the Using chamber experiments where we can actually measure chloride transport directly and have half of those cells exposed to the drug and half of them not exposed, and look at the impact on chloride transport in an Using chamber to compare to the sweat test. So we have a couple of ways of looking at drug responsiveness in vitro, in the laboratory, test tube kind of a thing, in the patient. We'll have our clinical outcomes. And I'm sorry that this is small. I couldn't figure out how to make this bigger because of the way I cut and paste it. But visit 1, visit 2, everybody will get 2 weeks of placebo and 2 weeks of drug, or 2 weeks of drug and 2 weeks of placebo. And I don't know who's getting what when. It'll all be randomized. One of our nurses is going to be the patient safety monitor who's going to look up the laboratory tests, so I'm not going to be looking at the lab results. And we'll see what happens. And we're going to, pick out a group of patients. It'll be about 30 people. And we're going to look for a signal. So we're not going to answer this question, but we're going to see, are the pancreatic sufficient patients? Do they have a bigger response than the ones whose sweat chloride is a little low? Or are they better? Or, maybe the girls on the track team and the swim team and whatever, maybe they're the ones that respond. And maybe we'll have some surprises. But we're going to look because we need to know. All right, so now, we have these other drugs in trials. You all know about them. 809, 661. There was an announcement of, 893 or something like that. Some other number from Vertex. There are rumors that other companies are going to get involved in this game, all of which I hope is true, because this is, this correction thing seems to be a really tough problem. So we need all the help we can get. We'll be looking at these things. Everybody right now, all the trials are focused on the 508. But, as we go forward, maybe the thing I've talked about here with ivacaftor, we should come back and, do this again with a combination. Because, 809 ivacaftor, frankly, if you look at the data, I'm not sure, I'm not very optimistic this is going to be a great combination. And I don't know yet about 661 ivacaftor. And I know nothing about 893. I don't know, Jeff, do you know anything about, or whatever that, is that 893 or something like that? Whatever, yeah. I don't know what they look like in vitro. And, the in vivo stuff, in the G551D patients, we're talking about a 45 to 50 millimolar drop in your sweat test on average, with all that variation around it, but huge drops. Now, with this, look at the means, 4, 9. These are small numbers. And people have started to throw stones at the sweat test as an indicator. But it is a functional test, and it is impacted by the function of the CF protein. So if it doesn't change there, if you get a big change in the sweat chloride, I would really be surprised if that patient doesn't respond clinically to the drug. If you get a little change in sweat chloride, could the patient still have a big clinical response? Yeah, maybe. It's going to be harder to predict that, but it's possible. I wouldn't rule that out. But, if we can see those big changes, then you presumably should see the kind of changes that they reported in the ivacaftor studies. And in terms of how this impacts individuals, you should see things happen like those 2 cases that I showed you where the man was on death's door and it saved his life. And my little 12-year-old friend where, she spent Christmas at home and she's taking 2 dance classes and in PE and she can walk at the mall as much as she wants. And, for me, that's a miracle. And she feels good. So, you know, I don't think we're there yet with the combinations, but I think as these things move forward, I really hope some of them get approved because I want to try them off-label. I want to explore it because I think, you know, the FDA, the way they do their business, I don't have anything to do with the FDA, so I guess I'm free to criticize. You know, they have these rigid rules, and if this drug weren't so incredibly expensive, we'd be exploring. We'd be out there exploring like crazy, but everybody's afraid to do that. This is an important plot, I think. It's not the be-all and end-all, but there's important information when you look at this relationship between these two things. So, you know, what do I think about the future of these CFTR modifiers and eventually the potentiators? The VX770 or ivacaftor, Kalydeco is going to expand to a larger group of patients, and we need to figure out who those people should be. And we may be surprised, I hope we are surprised by some of the people that we find, the individuals who respond to this drug. We're going to have competing drugs. I mean, this is just the first drug, and I would hope and pray that it's not the last drug of its kind that comes into our potential therapies for CF patients. Combination therapies clearly are needed and inevitable, and boy, we've got to figure out a way to make these things cheaper, otherwise we're going to bankrupt our healthcare system. And I would argue that this approach, the pharmacologic approach to CF treatment for the next several decades is the most promising area that we have. You know, we can talk about gene therapy and all that, but that is a really tough thing to do. And it's going to take us many decades to become smart enough about how to manipulate genes safely to actually cure CF in the sense that we replace that defective gene with a properly functioning gene. But the pharmaceuticals, you know, we've got the first one, and it shouldn't be the last one. So, in the meantime, we need to learn who will respond to which drug or combination of drugs. We need to explore different uses. I mean, think about it. These have been tested for continuous use. One of my girls with a pancreatic sufficient mutation is a jock. Basketball player, soccer player, lung function, completely normal and above average. And when I say above average, I mean above average for anybody. What if next month she acquires Pseudomonas, which she's never had? Well, let's say she got it and she takes a big tumble. And if I know that she responds to this drug, why wouldn't I add that into the mix with my IV antibiotics and my chest physiotherapy and the hypertonic saline and all the other things that we've been doing for years? Why wouldn't I put this into the mix for a week, 2 weeks, a month, 3 months? I don't know how long. But normalizing or doing something to improve the function of her CF channels in the short term might allow her to get back into her athletics and all the other, you know, her normal life, and might bring her lung function back to where we started and might help prevent long-term damage. Why wouldn't I use it that way? If I get a chance, and if I know that she responds, I will. She's going to be in our study. I hope she never has that happen to her, but if it does, we'll be ready. What about prenatal exposure? You know, I've talked to the Vertex people. They don't know whether this drug crosses the placenta or not. This drug has not corrected pancreatic function in the G551D patients. And the reason for that is they're born with a pancreas that's basically totally bunged up. You can't fix it at that point. It's gone. And if you look at fecal elastase or pancreatic function on the drug, it doesn't change. I know because I've measured it. But if you gave it to mom while she's pregnant and you correct the function in the fetus, then it's very likely that this child would be born with a normal pancreas, normal pancreatic function. And not only would you avoid pancreatic insufficiency and all of its problems, but CF-related diabetes which is a big problem. As you get into older CF patients, 30s and 40s, the percentage of CF-related diabetes goes up and up and up, and it has all the dangers of diabetes in anyone, of kidney failure, all those problems. There are some problems it doesn't, or some risks it doesn't give you, but it gives you serious, serious risks for chronic and life-threatening health problems related to CFRD. We could potentially prevent that by starting it, giving it to a fetus. You could prevent meconium ileus, potentially. If you had these drugs, they cross the placenta. You know, we have babies with CF that die because of meconium ileus still, because it's a surgical problem and there's big risk. It's about 10% of CF kids. You know, you potentially could prevent it. I don't know that this is all true. I'm just speculating here. I want to make that clear. I don't know that this is true. And then the thing that may help drive the cost down is if we find out that this drug actually helps in non-CF chronic lung disease, because then you're talking about huge population, you know, all the reformed smokers who have COPD. If it turns out it actually helps them, then maybe the price of this drug will drop, because that's a huge population compared to CF. So, you know, I don't know for sure where this will all go, but it's a very exciting time. There are lots of possibilities, and we should keep our eyes and minds open to those possibilities. And in a way, it is a dream come true. You know, I'm old enough that I remember the bad old days. Things are a lot different than they were 30 years ago. And another 30 years from now, of course, I won't be around then, most likely, but another 30 years, I would hope that they would be even more dramatically different, and that kids who are born with CF mutations would live long and happy and normal lives. And I fully expect that's going to happen, because we've already seen the beginning of this, but it's just the beginning. So, thank you.
Dr. Nielson, could we take just a couple of questions if we have any?
Sure.
Great. Oh, thanks. Does anyone have any questions? Or are we going to just do some digesting here of a lot of great information? I think it's on. Sorry. Might give it a try.
Could you give us a quick update on your knowledge of the phase 2 and phase 3 trials for the double deltas, the combo therapies? Are those looking promising?
I think it's a mixed picture at this point. There was some data that was just released that suggested that the clinical impact was greater than one would expect based on the sweat chloride changes, which were quite small. So what I said about, you know, sweat chloride is not completely predictive of what will happen may be true. I mean, I hope that's true. But at this point, we really don't know. It's going to take more time, more study. And I actually think we need better drugs. And I don't know whether they're there yet in terms of the corrector part of that. I can tell you some of my basic research friends believe that it's going to take 2 drugs to do the correction in 2 different places in the cell, plus the ivacaftor to turn it on. So it may be a triple combination in the long run.
One more question. Here you go.
I have a question about pharmacogenetics. Are you using any of that in your study, the P450 allele discrimination for drug uptake and elimination?
Not yet. I mean, those are interesting questions, and I think that where we will look at that is with the surprises. You know, the patients who are doing extremely well with severe mutations, you know, what's the story there? And Dr. Wine and I have talked a little bit about this a few months ago, and his idea was that there was something different about the processing of the protein in the cell, and maybe it wasn't quite as efficient as average, and it let more protein through. The other alternative is that when we do gene screening, if you find 2 508s, you're done. You don't look at the rest of the gene. And maybe what we need to do is we need to sequence the whole gene, because we know from our newborn screen that there are a subset of patients that get sequenced where they have one known mutation and then in a high IRT, and we end up sequencing them, and we find 3 mutations or 4 mutations in some cases. And the kids that I've seen so far that have had 3 mutations have all had normal sweat tests as infants. So, you know, you may have a 3rd or 4th mutation that actually corrects the problem. That could happen too.
I have a question from someone who's watching online, and that is when you were talking about the girl that was taken off of Kalydeco because of her liver functions, did she have previous liver issues?
No, she didn't. And she, you know, she was on a lot of drugs because she was in the hospital at that time, but she'd never had an elevation of her liver function tests before. And I went back, I've looked through the reports that are published, and it's really hard to find any reports of these kinds of elevations, but in talking to people sort of off the record, they did see patients where there were 3 to 5 times elevation of above normal of liver function, and they plateaued. With her, we weren't seeing any clinical benefit, and we saw an exponential increase, and so we just backed off at that point.
Thank you.
You actually answered, I was going to make a comment that I know of one other patient who had their liver function deteriorate on ivacaftor, and it might be really useful to sort of check around and see how many of these there are and if there's any commonality, because ivacaftor is a remarkably clean drug, and so I was really surprised to hear that it had, well, if it does have that, I mean, you may need a variety of other confounding factors before you see that.
Yeah, I don't. I mean, we were obviously disappointed that we had to, that we felt like we had to back off. So, Jeff, on those patients, did they plateau at some point, or?
I don't know, but I can tell you who to talk to, whose patient it was afterwards.
Okay.
And that is the time that we have. And we want to thank you again for making the drive through, all the traffic to get down here, for the time it's taken for you to join us tonight, and for this very hopeful look at where we stand with medicine today for cystic fibrosis. What we're going to do now is just take a 5-minute break. We will show a brief video at the end of our business meeting. Our business meeting is short. So I encourage you all to go right over to this corner where dinner awaits, well, kind of dinner awaits. Thank you again to Dr. Nielson.